Welcome back, Health Impact audience. All day today, we've been talking a lot about different topics, starting from our almost our most popular topic, which was how do you stop doing stupid stuff, all the way through to workforce and other things. But we thought we'd cap off the day today with a very forward-looking topic, which is how has the healthcare system we want changed, which means pre-pandemic, we might have wanted certain things. Post-pandemic, we might want other things now that we've learned how to do things in 1 year that would have taken us 5 or 10 years to do in any other way. And we've got a great lineup for you here. Everybody from a full health system leader like Stephen from for 18 different hospitals, all the way through to Erica and Daniel, who are managing local environments in very different kinds of both underserved and regularly served areas. And Mona's coming in from the payer angle. We love to blame payers for everything. So anything we want to blame for any payers in the country, Mona has accepted, volunteered to take all that beating from us. So this will be a great way to start. So with that, I'd love to have Dan introduce himself, and then Mona, then Erica, and then Stephen. I'll give Stephen the first question as well. So Dan, go ahead.
Sure. My name is Dan Duran. I'm the Chief Innovation Officer with LifeBridge Health. And LifeBridge is located in the Baltimore, Washington area. We're a small to mid-sized health system, 5 hospitals. And within the innovation role, I oversee a lot of our payer provider work, as well as our digital front door and some of our physician access and telemedicine type strategies.
Excellent. Mona?
So I lead enterprise clinical strategy and quality for Humana. We are one of the largest Medicare Advantage plans in the country, but we are also making a transition over time to being a healthcare company with an insurance arm. So looking forward to bringing both the provider and the payer perspectives.
Excellent. And of course, you used to work for the feds as well, so you've got a little bit of
That's right.
Background there too. Erica, your intro.
Well, good afternoon, everyone. My name is Dr. Erica Steed. I currently serve as the System Chief Operating Officer for Sinai Chicago Health System in Chicago. We are very a small but mighty healthcare system, really focusing on healthcare disparities and really driving health equity for the underserved communities. As part of my key role, I am quarterbacking a large scale transformation effort that really bridges the gap in our current dynamics in healthcare and really innovating us and escalating us to the future. So very delighted to be a part of this distinguished panel and a very, very interesting topic.
Excellent. No, welcome, definitely. Stephen, tell us a little about yourself, and then I'll ask you your first question.
I'm Steve Klasko. I'm the president of Thomas Jefferson University and the CEO of Jefferson Health. Whatever Mona is, I'm the opposite. In July will be an 18 hospital system that is now also acquiring Medicaid and Medicare Advantage plans. So we're going to meet in the middle somewhere, but we're the largest health system in Philadelphia. And I think, what's unique about us is that we've recognized where things are going, and our whole mission is to be healthcare at any address, which is sort of a bit different than many of the traditional academic medical centers.
No, it's excellent. And maybe that's a good place to start is that what, Stephen, do you think you've learned over the last year or so heading up this very large system? And of course, you had a big fight with the FTC to get to your large 18 hospital system. So beyond that, you've taught us a lot, especially in prior sessions at Health Impact, about preferences of patients really mattering a lot. And is that, have we doubled down on that that you've shared with us in the past, or are there other things that you've learned about what should we be aspiring to more in the health system of the future, knowing now that in a year we did, literally what we would have taken 5 or 10 years for us to do, we did it in a year. Can we do more than we ever thought possible? And what might that look like?
Yeah, so since this is the 22nd panel where people have asked me, what did the pandemic change? I'll give you the same answer I've given the other 21 times. I don't think it changed anything that we didn't know before. I mean, we knew it, it just made it more obvious. So, if you just think about healthcare policy in this country, we've spent the last 12 years figuring out how we can give more people access to a fundamentally broken, fragmented, expensive, and inequitable system.
Mhm.
But we really haven't done the hard work to transform the system, because the hard work to transform the system is going to disrupt somebody. Just real quickly, there was a great book when I went to Wharton. A guy named Bill Kissick wrote a book called Medicine's Dilemmas: Infinite Needs, Finite Resources. Sound familiar? That was 40 years ago. And what he said is, we had the iron triangle of access, quality, and cost. He said, if anybody ever tells you they're going to increase access, increase quality, and decrease cost, and it's not going to be disruptive to somebody, they're not telling the truth. So think about it. President Obama said, good news, the ACA will increase access, increase quality, and decrease cost, and it won't be painful. Impossible. President Trump said it's going to be like fantastic, terrific, unbelievable, and huge, and it was none of those things. So the fact is, we aren't incented to change, generally. The providers are incented to get as much money into their sick care model as they can. Traditionally, insurers have been incented to decrease the medical loss ratio. Pharma has traditionally been incented to get as much of their expensive drugs sold. And we keep talking about this myth of going from volume to value, but we really haven't transformed it. So the pandemic obviously changed some of that, except when it comes to the healthcare inequities, I would argue it made it worse. I mean, if you want to look at one thing, it's broadband. 22% of people in Philadelphia do not have broadband. So if I asked you a question and said, what was the number one reason you got hospitalized in Philadelphia or died from COVID in Philadelphia? And I said, you deciding not to wear a mask? Yeah, that's a big one. You deciding not to social distance, your genetic code or your zip code? The answer is not A, B, or C, it's D, because you couldn't access telehealth or you couldn't access online education. So it sounds almost trite to say this, but we've known for 20 years that 80% of a person's healthcare is what we spend about 10% of our dollars on. And I think that the pandemic just proved that. So finally, what I'd say is the jury's out whether or not this has long-term effects. The jury's out. I already hear some of my colleagues in the provider world saying, well, okay, I got to fill up my hospitals again because I really lost the money. I've heard some of my colleagues, not Humana, but some of my colleagues in the insurer world saying, well, we're going to go back to giving people $49 for a telehealth visit and $250 for an in-person visit. So the jury's out, actually. Is this pandemic a blip, or is this pandemic the Amazon moment in healthcare?
Got it. Yeah. And Mona, from the Humana perspective, you guys are thinking you want a different system, which is why you're looking towards heading more as from just the insurance side to the provider side as well. Talk a little bit about that strategy and what is it that Humana sees, 3 to 5 years from now that the healthcare system should become, and that's the direction you guys would like to take us to.
Yeah, that's a great question. I think the system needs to look fundamentally different than it does today. I would agree with really everything that Stephen said. I think what we've seen over the last year is just a magnification of the inequities in the system that have always existed, which we just have not focused on as a society. I think, just to kind of respond a little bit to what Stephen said, I do think that there's going to be a level of intentionality required for the things that have happened over the last year to persist. And it's going to require partnerships across a range of stakeholders in the ecosystem. So really engaging with the provider community, the payer community, the federal government, and how many of the policies that were instituted in the last year actually, stay on moving into the future. I think overarching for me, one of the things that I care deeply about is how do we shift more care into home and community-based settings. I think it's the way we all want to age over time. And how do we maximize the right things going into an acute setting versus enable the right care at the right time for families and their caregivers in their homes. So you see some of the investments that we're making are really a testament, I think, to that philosophy. Both in the primary care clinics and the investments that we're making there, but also in the home segment, the investments that we're making in primary care in the home and urgent care in the home, and frankly, in our digital health infrastructure as well, right? So how do we ensure that the right level of care is showing up at the right time? And I should also mention the largest home health company and palliative care company in the country as well within the Humana family. So I think you're seeing this transition of us, really thinking about what's required to enable us to provide more of that care in home and community-based settings. I think the challenge for us is going to be, how do we knit all of that together, right? How do we figure out what's the right thing and what's the right level of care for that individual? And then how do we care for the social determinants of health that we talk about so much, but that haven't been really knitted into the system. I think Humana has taken some significant strides in that space, but how do we make sure that the information about a person's, social infrastructure is as readily available to us as their medical and clinical information? So, I would say, for us, primary care in the home, and then really enabled by a data and digital infrastructure that can actually propel that forward and make that a reality. Those are the areas that we're really focused on.
No, I love that. In fact, having worked with Humana for a number of years, just like Stephen, one of his favorite insurance companies is Humana, as is mine, because you guys are thinking 2 or 3 years down the future, more than just what an insurance company would do. So that's great. So Dr. Steed, talk a little bit about your small but mighty, what makes you mighty in that particular case, and what could the future insurance companies of the world help you guys with to actually move your mission further faster as well?
So small but mighty, meaning we have a very, very specific focus on the underserved and vulnerable communities. And that's what I believe we do well. So we are a safety net healthcare system. We're the largest private safety net healthcare system in the Chicagoland area, as well as the state of Illinois. So with that being said, I think that there's a multitude of factors that have been impacted on the wake of this COVID pandemic. And in my perspective, I think that progress has been stalled in many respects, but simultaneously, we've been propelled forward to embrace different mechanisms of care, such as virtual health. Telemedicine is certainly on the forefront. It certainly has disrupted operations in a lot of ways, and we truly had to build the plane and fly it at the same time as it relates to re-architecting just the way we do business and the way we provide care. So we're certainly have been challenged with evaluating the correct provisions of care. And from a payer perspective, certainly we're very challenged in terms of aligning with appropriate means of pay for performance based off of an old standard. So I think that the dynamic has changed in terms of what's really showing up under our 4 walls, and being able to demonstrate value in the same way that we were compared to in the past. The lengths of stay and transitions of care is much more challenged. The transition to the ambulatory environment and the expansion of needs of primary and specialty care has certainly been heightened. So for us is just a matter of the surge of demand of what those key components are, staying true to our mission of really caring for the underserved, vulnerable communities, and eradicating healthcare disparities when the alarm has certainly been sounded, and the spotlight certainly has been cast on the gross level of disparities that actually are showing up on the wake of COVID. So is actually demonstrating validation of who we are as an organization, but is compounding the need for us to accelerate steps to really pull it together.
Yeah, no, I think you definitely think things have been highlighted, but like Stephen says, we knew about them before, but now that they've been highlighted, the question is, what do we do about them? And Dan, I'd love to bring you in. So I live in Silver Spring, Maryland. We're neighbors, in fact, so LifeBridge is not too far from me. I know you guys, right before the pandemic, started talking about the unbundling of healthcare, unbundling of services, and thinking about how bundles could be moved around. Is that the same direction and you're doubling down on that? Or what have you seen over the last year that now you are able to do things faster and in more compressed times? Are you thinking about it in more broader terms, trying to do things faster in that same strategy, or have you changed strategies at all?
I would say it's more toward doubling down, but I also don't want to imply that we have all the answers a year ago that we needed today, right? Mm-hmm. We're not omnipotent. One of the themes, listening to the other folks speak, that we were directly experiencing as far back as 3 or 4 years ago, is we were trying to transition all of our primary care doctors to have as much of a virtual offering as they could. And it was actually quite a challenge. And this is very much sort of practice by practice, change management, and getting those doctors that had done a whole career or part of a career in a different paradigm that's more bricks and mortar, getting them excited about seeing patients virtually and getting the patients excited about it, even when it might be the right venue or modality. It honestly was an uphill battle. And so we saw a very modest growth of those things, even as the innovation team was sort of leading the vanguard and trying to get people to see the possibility. So I would say to Dr. Klasko, I do think that there was, whether it's an Amazon moment or a Netflix moment, whatever we want to call it, I do think that this last societal global experiment of the last year, where all of a sudden the world is turned upside down, and suddenly both the consumer, the payer, and the provider all need to experiment with virtual health, that has unleashed a tremendous amount of experiences. Some of those experiences have been positive, some have been negative, but there will be stickiness to those positives. And I think we will never see 1 or 2% adoption of telehealth based on what I'm learning from my network. Many of these providers, particularly the earlier and middle career, to get granular about it, who are a little more EHR friendly and a little more video friendly in terms of their work habits, they are now totally re-envisioning the way that they will reopen and run their practices, and in fact run their lives as human beings, spending some days in clinic for those types of encounters where virtual is not an option, but really flexing that virtual as much as they can. And you hear the same thing from patients. And I can say that for me, I did my primary care visit virtually this year, and I'm not afraid to say it, and that was an option for me last year, but wasn't one that I pursued based on the circumstances, right? So I think we are still thinking about unbundling care. And what that means is to really, the way we use that term is what needs to happen in the office, what can happen at home, what sorts of technology lets us transition more and more outside of either an acute care setting or an office setting. This is not unlike what Mona has already referenced, and Humana has probably done as much work as anybody on this. So I think we all knew that was going to happen. I mean, we've known this since people have been writing about this in Harvard Business Review, in places like Wharton for the last 30 years. We know that there's an aging population. We know that most people want to die at home, and relatively few people actually get the opportunity to die at home, or even to, have the last 6 months as much at home as they'd like. And there's all kinds of things that are not even palliative, but that more longer term care that can be safely done at home, that is done in long-term care facilities. And with the Medicare, entitlement crisis looming and everything else, this is an important thing for our society to figure out. Well, this year has been a tremendous source of inspiration and experimentation along those lines. And I think those organizations that continue to learn and think about what's safe to put at home and how to position themselves so that they're benefiting from what's best for those patients and not just what's best for their legacy sick care model, those are going to be the provider organizations that thrive. And the last thing I'll say, it's a little bit easier in Maryland, since you referenced Maryland, to do that because we have capitation at the acute facility level, and it makes it less painful. You're not so much sacrificing growth when you invest in these other growth areas like urgent care, which we've done quite a bit of, telehealth, home PT, home care, and you go on down the line. If that's the growth area of the future, then in a state like Maryland, health systems are more free to invest there because they don't have the volume expectations around maintaining their facility payments. They can sort of look at their facilities and say, what needs to happen there? Let's double down on that. But they don't have the pressure necessarily to run the volumes, the surgical volumes through that you might see in other geographies.
Yeah, that's a great point. Yeah, in Maryland, we do have global cap, so it makes things a little bit easier because we're forced to. So, Stephen, you run an 18 hospital system. You're head of the system. What are the gauntlets that you think you could throw down from a leadership perspective to say, look, we have now learned, just like Dan and Erica and Mona have said in the last year, much more. The grand experiment has been run. What are the gauntlets that we could throw down to solve some of the problems that you're talking about? We've known for a long time. But is there anything that has happened in the last year that could force the direction to go faster, better in ways that you thought we could be doing rather than we are doing? What gauntlet would you like to throw down, Stephen? And you're on mute.
The two gauntlets that became incredibly clear is one that you have to have strategic alignment between the provider and the payer, right? So, if you look at places that did okay, through this, it was places like Kaiser or UPMC or whatever, or had strategic alignment, or were in the percentage of premium. And the second is you have to diversify your portfolio. At Jefferson, we're doing both of those. When I say diversify your portfolio, we recognized about 6 years ago, we called it the old math and the new math. And it frankly came from my work in Apple. I worked in Apple prior to the iPhone, and the old math was computers and operating systems. The new math was this digital lifestyle. The problem is everybody working at Apple was only working on computers and operating systems at that time. When I came to Jefferson and said the old math is hospital revenue and in-person tuition, and the new math is innovation, strategic partnerships, and digital transformation, I got the same thing from our faculty. Wait, all we do is hospitals and inpatients. So we had invested, and I think this gets to Daniel's point of it's hard to get somebody to do something when their salary depends upon them not doing it. I think that was an Upton Sinclair quote that, we invested $40 million in Jeff Connect, the telehealth program, originally in partnership with American Well and then with Teladoc. It's a specialty run, emergency medicine run telehealth system that became at one point the largest specialty telehealth system. And we came up with a model where we could move 50% of our patients out of our expensive, inefficient ED to, as Daniel said, urgent care, telehealth, or an internet appointment the next day. So that was awesome, except the way that our insurance providers were back then, we would make an average of $1,500. Somebody came to our ER whether they needed to or not, waited 5 hours and got 2 CAT scans, and an average of $49 if we did it the other way. So we started with our 32,000 employees. In this case, our TPA is Aetna, and we created a differential copay model. So here's the story: if you come to our ER having gone through Jeff Connect, 0 deductible and 0 if you get admitted. If you just show up to our ER, you're paying a percentage of both your deductible and your admission. The first 6 months we saved for those 32,000 people, because we're the provider, the payer, and the employer, we saved about $7 million and had record patient satisfaction among those employees. So I think that's one piece that clearly we are going to double down on with new partnerships, not just with telehealth. And I think the issue with telehealth is, and I really believe this, we have to stop talking about the technology. We don't get up in the morning and say, I think I'm going to telebank. It's just that banking went from 90% in the bank to 90% at home. We have to look at the combination of things to do that. The portfolio diversification thing, I think, is also interesting. I decided that I would never, ever, ever again go to HIMSS and have 987 24-year-olds tell me how they're going to transform healthcare with their app. Because it might transform their wallet, but it's not transforming healthcare. So as you know, and we talked about this, I wrote a book with Hemant Taneja, the head of General Catalyst, who started Livongo, called Unhealthcare, a Manifesto for Health Assurance. And it starts out, what if a Silicon Valley entrepreneur and a CEO of a 195-year-old academic medical center walked into a bar, got married, and had a kid? And we created that kid. It's called Tendo. So we took our entire digital innovation team from Jefferson. GC moved a group out to Philadelphia, and they're now on my cabinet. So we're literally bringing that, and they've learned that moving fast and breaking things doesn't necessarily work in healthcare. Mm-hmm. We've learned that the risk aversion that tends to happen in academic medical centers doesn't work. And we brought that together in a very different way that's not a vendor-vendee way. So on the diversification side, we no longer do any vendor-vendee model. If we're going to do something with a digital transformation company, we get stock in it. That was true with Livongo, that was true with American Well, et cetera. This year, while hospital revenues went down, we had a net operating income of about $80 million from those partnerships. Wow. Think when IPOs and those kind of things. So I think those were the two things for us that we learned.
No, it's fantastic. And I love that idea. And thinking that same way, Mona, what have you learned, and if it could be more broader to Humana, that's great as well. But what are some of the surprises as you come into Humana, looking at the provider-ish kinds of lens where you're becoming a healthcare company? What has surprised you, or, what are some of the myths that you had to bust yourself about what a health insurance company was capable of doing?
So I think within the context of COVID, to Stephen's point, I think looking at novel partnerships was really, really critical for us, right? And not starting with what is it that we do and what is it that we want to do with that individual, but what is it that they are telling us are their needs, and how do we meet their needs? And really understanding, from kind of people's basic needs to their clinical needs, what is it that we needed to do? What were the partnerships that we needed to bring? And I love that point of not having a vendor vendee relationship, right? But really thinking about it as a partnership, which inherently to me is something that is repeatable, right? That is not something that you're putting towards one use case and it's one and done, but it's something that becomes a part of your infrastructure that you can apply across the board and make a more seamless experience for your end users. And so I would say that was probably my single biggest lesson, of course, in that context of COVID, of we can provide everything that people need. The thing that we are trying to do, maybe from a historic position, isn't the thing that people need right now. And so how do we make sure that we stretch the way we think about ourselves and our place here to play, and really think about addressing those more immediate needs. I think the entire system, frankly, has had to do that, of thinking about consumer first and what are those needs that we need to address. I think we need to do much more of that, so that there aren't these point solutions that we're throwing at people that, again, are sort of one and done, but that we think about what that end-to-end experience looks like for that individual. The most, perhaps one of the most frustrating things for me, is to see all of these point solutions that are thrown at us every day, that create that perpetuate the silos within healthcare. And my focus really is based on many of the lessons learned last year, but I don't think that they're all new lessons, of how do we create those more seamless experience for our consumers. The ways in which all of us now are used to getting services has really changed over the last decade because of Amazon and others. And I know it's sort of trite and we've talked about it, but there has to be a level of intentionality in creating for healthcare to bring to consumers not just the right care and evidence-based care, but care that's delivered in a seamless way that provides a good experience for both them and their families. The extent to which, frankly, healthcare has forgotten about the end user and the consumer is just shocking. You sit in an ER and you sort of look at the activity around you, and you think about the fact that you are just another piece of furniture, oftentimes the way you sort of feel in that setting. And I think there's just so much more that we can do from a partnership perspective to really meet the needs of our patients in a much more effective way. So for me, sort of those lessons learned and moving forward, I think you're going to see a lot more intentionality from Humana in how we think about building those experiences and really thinking about them as experiences for our users.
No, that's perfect. And Erica, when you think about what Mona just said, and Stephen put down the couple of gauntlets about where to head, that's all great. The question for you guys is, you have limited resources. The underserved is who you're focused on. What do you need more from your partners than just the money? Money is actually helpful and that would be useful, but what more could you use from the partners. And what have we learned over the last year is that things can accelerate if we want them to. And so based on what we've learned in this grand experiment, things that could accelerate, what would you ask for from partners? I don't know if Humana is in the Chicago area and in your service area, but if you had a Mona or like Humana in your area, what would you ask them for to help you guys out?
Yeah, I think that's a great question. So first and foremost, being a safety net organization with very scarce resources, most definitely the lesson learned that I reflect back on is how much unintentional silos have been created in the space of healthcare in general. I think that we're all in our own fiefdoms and intentionally focused on what needs to be done. But I think from a partnership perspective is bridging better alignment around what our core priorities, what our core needs, what our core solutions are, so we can work collectively as opposed to individually, and creating unnecessary redundancies that most definitely impacts the end user. We care for such a high risk, vulnerable population that certainly has shown up in the wake of this pandemic. I think that we can forge some great alignments around the ambulatory care, the virtual care, the post-acute care needs, whether it's in an LTAC environment or a skilled nursing facility, home health facility, whatever. So as opposed to going about this in an individualized type of way, essentially meeting the needs of one particular organization, I think that we need to work collectively as multiple subsets of an organization to really drive at that. And that way it lessen the over-reliance and dependence on state resources and the various managed Medicaid organizations that a safety net organization like Sinai is heavily dependent on. So I think that is the spotlight from my perspective. And again, I made mention that this truly was a building of the plane and flying it at the same time. Now, while a lot of these opportunities and challenges were readily known, we literally had to accelerate a lot of these things forward at the same time, where it really jammed up the system in a lot of respects. So just taking a couple steps back, what would Sinai Chicago and other respective organizations comparable to us need? I would just say much better synergized alignment and better integration in collaboration across the board that will lessen the load on one organization.
Yeah, that's great. And I think partnerships have come up a few times. And Dan, of course, being again in Maryland area, you've got Global Cap. What have you guys learned in the Maryland area about partnerships and where they would work versus partnerships? And, it's stuff that we talk about in these kind of sessions to make us all feel good about partnerships, but you can't really pull them off because there's too much competition. The competition is not going to just subside because we want to be, hugging each other, on a session like this. So what kind of partnerships would work and what are not really working, and how could we improve those to help out folks like Erica? And of course, you guys in the LifeBridge area, you have, same kind of safety net kinds of folks as well in various areas. What are you doing with partnerships?
Yeah, well, so much of what Erica is saying resonates with me. LifeBridge, our number one hospital, or our largest hospital, put it that way, is an academic medical center called Sinai Hospital of Baltimore, which shares a lot of the same challenges as Erica was describing with her Sinai Hospital. But I could really, take your question and I want to speak to Erica's call for alignment, Mona's call for a seamless experience, and Stephen's challenge to sort of own a big portion of one's interactions with startups. We are combining all of those considerations with what LifeBridge has decided to do. And what I'm going to describe is, is what we've decided to do. It's not like a strategy for everybody, but in our geography, so much of the alignment and what works and doesn't work is determined by the largest payer in our geography, which is Care First, Blue Cross Blue Shield. So we are combining our innovation teams with theirs. They have a subsidiary called HealthWorks, and we've actually built a startup incubator that can hold between 20 and 30 digital health companies on the Care First campus. It's called 1501 Health, in recognition of their street address, which is 1501 South Clinton Street. For those familiar with the Baltimore skyline, it's the big building that kind of stands to the east, separate near 95 as you drive through from the rest of the skyline. And we actually have co-located with folks over there. And the idea is something like this. I recognized during my days with Evolent Health and other digital startups that there's almost like an arms race in a way on innovation between payers and providers. Providers will innovate and they'll come out with something like a new diagnostic test or CT scan. And then payers will innovate with some sort of gating process like a benefits management that or site of service modulation that is intended to mitigate some of the overutilization. And rather than both spending on our separate innovations, the idea was let's be on the same page as early as possible as we invest in startups like Stephen's talking about doing, as we think about the digital patient experiences that we all want to craft for patients. The more that we're on the same page about how that should look, the standards they should use, and maybe even the exact companies and API, we can maybe provide a more seamless experience, as Mona referenced. And from the perspective of an inner city hospital with all the challenges that entails, and Erica went into some of those, having that sort of privileged innovation venue for us to work with Care First as a major payer who's increasingly taking on government books of business like Medicaid as well, puts us, I think, in a good position to be the authors of our own destiny with regard to some of those considerations.
No, I love that. In fact, I think that's the only way that we're going to work out of this situation is that the Humanas and the Jeffersons and the Mount Sinai's, they have to work together with their payer partners. Their other partners, by the way, employers. So one of the big problems in our country is employers don't actually realize how much power they have to influence all of this, right? They've almost like gated it and handed it over to others. And so this I love is, Daniel, is that if you guys and we'd love to have you come back, and we're down to about 30 seconds. So I'll just summarize real quick, and we'll open it up to questions here as well. But if you can look at partnering up with also employers in the area that are big enough to be, whether they're self-funded or not, isn't the question, but big enough to influence employees and influence the direction of some of these. The tech isn't the important part, but the tech moves people in a particular direction that they wouldn't without the tech in many cases. That is just awesome. So Stephen, I'll let you take the last word. Go for it.
One other thing I want to add, I think something we could all agree on. We have to make sure that this $1 trillion is going to be spent on digital transformation that we're all talking about doesn't just make the wealthy healthier. And that we're thinking about putting ethics into the beginning of this fourth industrial revolution, right? So if you just think about it, this is something that Humana and I have talked about with Center for Responsible Innovation of, if we knew in the industrial revolution that the internal combustion engine might cause climate change, maybe we would make some changes, right? If we knew that, Mark Zuckerberg wasn't just a guy with Asperger's who was going to let me see my my grandkids on Facebook, but could actually affect elections and spew hate, we might have, put some guidelines in. As we start to think about AI and genomics and drones and all the other great things, 3D printing, et cetera, how do we make sure that we're maintaining privacy, that we're having things like enhanced consent, that we're putting ethics in the beginning so that we're not 10 years from now having Senate hearings on why don't we think about that? Because unintended consequences are not unintended if they're going to happen. So I think before we get too excited about it, we have a lot of work to do. And I know it's something that Mona in her time with CMS is something that I know you spent a lot of time thinking about, but I think now that it's really happening, we've all said that, now that it's really happening and it's getting adopted, let's put those guardrails in as early as possible.
Awesome. Well, this is the perfect time to open up the Q&A to the audience. So you've got about 10, 15 minutes. So please do ask your questions. If you want to come up on camera, you can do that. Otherwise, we'll take your questions via chat. Stephen, thank you so much. Erica, thanks a lot. Mona, Daniel, and we'll turn you over to the audience now. We appreciate it. We've got the crew here. All right. Stephen is coming on. Mona's coming on. But we've got Erica and Dan. Now it's just Mona left. So we'll give her a minute to join here. This discussion, it's the closing keynote of the day. We've had a pretty lively set of discussions already during the day. We started our morning off in the West Coast, afternoon in the East Coast, with how to get rid of stupid stuff. And what we're ending the day with is the panel about how has the healthcare system we want changed. And so we've learned a lot in the last year, and this discussion really is going to be about what do we want our healthcare systems to become now that we've gone through this hybrid model. We know what things may or may not work a little bit better than we did a year ago. So that's really where we're going to spend a little bit of our time. And of course, during those two, between the top of the day and now, we've had a bunch of other sessions on workforce, cybersecurity. We had a really good discussion with another one of your colleagues, Stephen Jefferson, about how should we in the healthcare community, especially health systems, work with vendors and in what way, and Stephen, you've made the point before that, vendors should be truly partners. And we had Judd making that same point as well on the couple of panels ago. So with that as the backdrop, how has the healthcare system we want changed? I wanted to, it's my pleasure to introduce Erica, Stephen, Dan. We've got Mona as well. So Erica, I'll let you go first. Give a quick intro about you and your role at your company. Then we'll go to Mona, then Dan, and then Stephen. And then I'll present the first question out to Stephen as well.
Hi, good afternoon, everyone. My name is Dr. Erica Steed. I serve as the System Chief Operating Officer for Sinai Chicago health system in the Chicagoland area. We are the largest private safety net health system, comprised of 3 hospitals, a large multi-specialty medical group, and also comprised of very innovative delivery arms, including Sinai Community Institute, which is a series of social services organizations, as well as Sinai Urban Health Institute, also encompassing a focus on community health workers and really driving and eradicating healthcare disparities. So we're a very passionate organization, caring for the most vulnerable Black and Brown communities. And that really is our goal, is to really elevate excellence and not just put a dent in the eradication of healthcare disparities, but really move to shatter that overall dynamic and really elevate health equity at its best. So very, very delighted to be a part of this panel today, and very, very intriguing topic.
Awesome. Welcome. Mona.
Hi there, Mona Speaky. I lead enterprise clinical strategy and quality efforts for Humana. Humana, as you know, is one of the largest payers in the country. We do cover both Medicare Advantage, Medicaid, commercial lines of businesses. But in addition to that, we are on a long journey of moving from being purely an insurance provider to being a healthcare company with an insurance arm. And to that end, have made investments within the home segment. We now own, or on the path to ownership, one of the largest home healthcare companies in the country, the largest hospice company in the country. In addition to investments in primary care in the home, urgent care in the home, and then, as you may have seen, investments in building out primary care clinics and care for our country, and continuing to build those out. Really, I would say our ultimate goal is to enable patients to get care in their home and community-based settings to the extent possible and appropriate, and to be a partner in that journey. For most of our members, especially on the Medicare side, we have a relationship with them for an average of 7 years. And so there's a lot that we can do and we should be doing and leaning in and helping upstream from disease prevention and progression to partnering through addressing social determinants of health, and to Erica's good points around health equity. That is a core component of how we want to operate in the communities in which we are. So I'm looking forward to this discussion today and appreciate the invitation.
Oh, of course. And for some of you who do recognize Mona's name from before she was at Humana, she was the chief data officer at CMS. So that's probably where you recognize her from, in case you're saying, I know I've seen Mona somewhere before. Welcome. Dan.
Yeah, my name's Dan Durand. I'm the Chief Innovation Officer with LifeBridge Health System. LifeBridge is a small to mid-size provider organization in the Maryland area. We have 5 hospitals and a large delivery network. Consists of many of the things Mona mentioned that Humana has on a national scale. We have on a more regional, local scale. We have a home minority interest in a home care company and a variety of other joint ventures, such as nursing homes, aging in place facilities, health clubs, really the full span. And we have 5 hospitals as well. And about half of our revenue at this point comes from outside the hospital, which we're fairly proud of. We provide care to 1 million unique individuals and provide the plurality of care to about 300,000 Marylanders. And my role in innovation is to focus on a bit of that, what's going on outside the hospital, as well as the different ways that patients engage with providers, whether it's digital or in the office or through a mobile clinic, what have you.
Yeah, and I think what you've noticed from everybody here so far is that they each have a different view of what the future of health systems should look like. And with the broadest view is Stephen. So Stephen, tell us a little bit about yourself, and then I'll pose the first question to you.
Thanks. Great to be here. I'm Steve Klasko. I'm the president of Thomas Jefferson University and CEO of Jefferson Health. And I guess the simple answer to the question of what's changed in healthcare is not enough. You know, I know, Shahid, we talked about this. I like to quote Jason Kidd when he went to the Dallas Mavericks and the team was 24-52. He said, we're going to work hard and turn this team around 360 degrees. We work hard. We have a lot of effort. If people talk about volume to value, people talk about health equities. And 1966, Dr. Martin Luther King said that, the greatest social injustice is inequities in healthcare. And interestingly, objectively, we haven't made that much progress. And if anything, the pandemic proved that based on who was hospitalized and who passed away. So Jefferson's an interesting story. I shamelessly stole our strategy from my time at Apple. I worked at Apple prior to the iPhone, and John Scully, who's now one of our advisors, had gone to Steve Jobs and said, look, you need to come up with a literally like 100-page 3-year business and strategic plan. I'll give you McKinsey or Accenture. It needs a lot of spreadsheets. And it took about 3 months, and Steve called John up and said 12 hours later, I've got your 3-year strategic and business plan. I said, how can that be? So he went over, it was there on the whiteboard. Year 1, we changed. Year 2, we changed the industry. Year 3, we changed the world. So I came to Jefferson in 2013. We were a 2-hospital system losing money. And we had a president of the university, a CEO of the hospital, and a CEO of the system. 3 different people that spent about 95% of the time fighting each other with 3 different boards. I came in as a single campus leader. And we took a lot of the things out of that kind of mindset. So the first thing we did is say, we have to change our mission. Our mission is to be the premier academic medical center in Philadelphia. Nobody cares about that except for me and my mother. So, we changed ours to we improve lives and reimagining healthcare education discovery to create unparalleled value. Why was that important? It sent an incredibly important signal in how we incentivize folks. 25% of my incentive, even though we're now an $8 billion organization, is reducing health inequities in Philadelphia, most of which I have no direct control over. Mm-hmm. But it also got some great folks over. We got 6 of the top, this is in 2013, 6 of the top telehealth people from one of the top 3 universities in the country. And it was because in our coming out party for this new mission of reimagining healthcare to create unparalleled value, they had an aha moment. And they said, you know what? We realized that we could win the Nobel Prize for telehealth and not make it to the cover of our alumni bulletin because our president's mission is to be #1 in NIH funding. I ain't going to help her in that. So literally that started Jeff Connect. So that was one thing we did, was we basically said, we're going to live a very different mission, which is outward focusing. The second thing that we shamelessly stole was Steve Jobs talked about, we're going to create the old math and the new math. The old math was computers and operating systems. And the new math was this thing that nobody knew about called the digital lifestyle. Not surprisingly, when he said, I'm going to move money from the old math to the new math, folks raised their hands and said, excuse me, Steve, you're either crazy or on drugs. And he was on drugs, but he wasn't crazy. The only math we have is computers and operating systems. But he was able to uniquely see what was going to be obvious 10 years from now and start to do it today. And that resulted in the first thing being the thing holding 200 MP3s. And that was the we change. We changed the industry was probably the iPad, and you could argue that the iPhone changed the world. So we did the same thing. I got in front of my faculty in my first meeting. I said, we're going to have the old math and the new math. The old math is academics, tuition, research, and clinical revenue. The new math is innovation, strategic partnerships, digital transformation, and philanthropy. That was in 2013. And they literally did just about everything they could to say, you're going to be the shortest tenure president. Don't you realize the only thing we have in revenue is tuition, clinical revenue, and research? So, but that's what led to a very, very different mindset, what we then called healthcare at any address. So I think that's the second thing that we've done. And I think the third thing we did is recognize that we need to diversify our portfolio. In order for that new math to work, I will never, ever, ever again go to HIMSS and have 920 25-year-olds tell me how their app is going to transform healthcare if I buy it. We now literally look at co-development and partnerships. And this year during COVID was a great example. Well, our traditional math, our old math, for all the reasons that folks on this audience know of, we went from $100 million net operating income projected to a $290 million loss. Our new math of innovation and co-development and strategic ventures, including a wearable that we helped develop, that then became an IPO, and a telehealth company that became an IPO, really brought us about between $50 and $100 million of net operating income that helped to defray that. So we are major co-developers. I'll leave you with this: that we're now, after a victory with the FTC, will be at 18 hospital, $8.2 billion IDFS with a Medicaid and Medicare Advantage plan, and a 2-campus university. But our overall goal is to be a 196-year-old academic medical center acting like a startup company. Because, for all of us, if we can take what we do really well, which is be a mission-driven organization, what brings all 4 of us together is we're very mission-driven organizations. But if we can be creative, nimble, and flexible, which is not what usually gets in the same sentence as an academic medical center, or really in most things in the provider or payer world, then I think that's going to be the secret sauce.
That's right. And I think, Stephen, I think you mentioned the startup mentality. And before COVID, that would have seemed like, a stretch for healthcare to use those two terms together. But I think today it's very easy to see that it is possible for healthcare institutions to be nimble by just changing mission, perspective, and knowing what's important. And when you think about it that way, Erica, I'd just love for you to comment a little bit on what Stephen mentioned with respect to if you can shift the mentality of your board, your staff, et cetera, you can do great things. Is that what you're seeing at your organization? And you'd have to kind of like switch that in order to be able to do what you're trying to do for the most vulnerable populations, some of the people who are not being served as well as they need to be. I mean, how do you get our attention to those kind of communities and try to create the health system that we want it to be, knowing now that in the last year, we have shown that if we wanted to, we can change rapidly, which means if we're not changing rapidly, it's because somehow we don't want to. Do you agree with that statement? And how would you use that to benefit what you're doing at your institution?
Thank you for that. And I think that was really a nice setup. So what the last year has taught us most definitely is, number one, we can accelerate change and paradigm shift our mentality if put into a position of force. So I think that we've been riding a certain wave and operating in a certain note for so long. And I always describe healthcare as being 10 years delayed and 10 years behind the rest of the other industries anyway. So, but what I believe the COVID pandemic has done for us is, number one, accelerated the momentum. So it has shifted us out of our comfort zone. So now we're being forced to be comfortable being uncomfortable, right? And we have to assimilate quickly on our feet. We have to think about the end in mind in terms of a much more consumer-focused aspect of healthcare delivery. And more importantly, I think that it has taken us out of a more of a siloed fiefdom mindset. It has forced coalitions and forced partnerships to really come together. So in my immediate landscape is extremely competitive in terms of competing hospitals and things of that nature. But on the face of the pandemic, we're no longer competitors. We're in alignment. We're in it together, and more importantly, it allows us an opportunity to really forge together on the same objective with the same agenda, and really combat some of these transformational change efforts that needs to be fought for with a unified voice. In prior worlds, prior to COVID, I would say we had our own individualized voice at the table that wasn't as large and powerful. So as we're being shifted into the world of virtual care and hospital at home models, and embracing telemedicine, we now have a collective unified voice really fighting for that and really striving for the advocacy that needs to take place in order for us to be successful and sustainable. This has also shifted in a lot of respects healthcare reform, right? So now the overall dependence and reliance on government resources and dollars to really navigate us through is not really a sustainable situation unless we challenge the entire dynamic in which the health industry is actually based. So we're challenging and accelerating healthcare reform, policy change, alignments with the payers, and actually ensuring that we're getting reimbursed now for services that has historically not been reimbursed. So I think that what's been brought about is an absolute challenge for sure, where we've had to block and tackle and build that plane and fly it at the same time, like I've mentioned. But at the same time, it is produced some pretty amazing fruits of the labor that many have been passionate about for too long. And then lastly, I'll conclude with some remarks about the mission of my organization, which has been focused for years on driving health equity and eradicating healthcare disparities and embedding the social determinants of health into the agenda. Now that we've sounded the alarm, because what has shown up is the gross inequity and certainly the disparities. So now that is a priority that is that I much appreciate. That's on the forefront for everyone.
Yeah, I mean, so that as if there were a silver lining to COVID, that is one of them. Is that nobody has to argue that health equity is a problem in the United States. It's clear for everyone to see, and now you actually have people who either will be standing in the way or be helping. And there are going to be clear distinctions between them. And that makes life much easier to deal with. So before people could say, oh, we don't have the data, we don't really know, are we kind of like overemphasizing, like we have the data now, it's pretty clear that there's a problem. Are you trying to fix it, or are you trying to prevent the fixing is the only one that we have to go with. So Erica mentioned health insurers. So Mona, what does Humana's viewpoint look like with respect to the health system that we now want, especially what we have learned is possible over the past year? What do you think you guys have learned, and why did you get hired specifically at Humana, especially coming from a lot of more provider background that you have? Is it because the Humana sees something about the convergence of the payer provider differently than other people are seeing, or is it something else?
Well, that's a great question. I often ask myself that too. look, I think in terms of where we think we need to move into the, as far as the future is concerned, I think a few things. One, the channel through which we deliver effective clinical care and seamless experiences can be multifold, right? So it can be in your primary care, clinician's office, and it can be in your home. It can be through digital means as well. So what I would say is that we're acutely focused on how we think about enabling the right care through the right channel at the right time to support that individual, to support their families and caregivers, and to ultimately enable them to stay in their home and community-based settings, which, I'll just stress, I think is so important to all of us as we age, and for all of our families as they age, and how are we really partnering in that journey. So for me, that's sort of the overarching goal. In terms of how we get there, I think a lot of things show up for all of us as consumers in silos and as point solutions. And one of the things that we really want to double down on is not just what's the right thing clinically, which frankly is not a hard thing to come up with. There's a lot of literature that tells us what we need to deliver to improve outcomes. But it's also about how are we knitting the experience from digital to in person to in an acute setting, and are we really thinking intentionally about the needs of that individual as we're designing these programs? And for that, you need not just the different channels through which you deliver care, but you also need the right information at the right time. And so investing in the digital and data infrastructure becomes incredibly important. Having the right information to say what is going to be important for this individual, what's salient for what they need at that moment, and then designing for that, that's really the hard part. There's a lot of intentionality in that. There's a lot of making sure that we are connecting the investments that we're making across the enterprise and being intentional in connecting those so that we're not just building, great products that are operating in silos, but really are maximizing their utility in service of our members. So I think that's where you're going to see an enormous effort from us in the next few years. And I think my perspective really is informed by two things. It certainly is the clinical, but it's also the importance of that information and the data. And thinking again of building that infrastructure use case by use case. So as we develop and deploy a particular clinical program, looking across the enterprise to say, what are the sources of information that would help us to improve that experience? How quickly are we getting that information? What are the ways in which we could decrease the time lag to make sure that we're getting that not in 24 hours, but in 2 hours or 30 minutes? What's required to get us there? So, I wouldn't say it's some, novel breakthrough that we're making. I would say it's really the nuts and bolts of how do you perform better? How do you design for what people need? How do you test it out in an iterative way and not launch a test that lasts for 2 years before you figure out that it's not delivering what you thought it should be, and really taking a mindset of we want to deploy small tests, learn, and then develop bigger tests, and actively solicit user feedback and consumer feedback and family and caregiver feedback to make sure that what we're delivering is meeting people's needs. I can't stress the importance of really getting that feedback from the end user, because as a clinician, I will say, even I took a family member to the ER some months back, and they were sitting on a bed in the middle of the hallway in the ER. And I was thinking of looking at all of the activity around them. and just realizing, just hit me, and I know it's hit all of us, but it was just so acute that healthcare it has not been designed for experience at all. It has not thought about the patient as a consumer who deserves a good experience. Frankly, I don't even think it's designed well for the clinician. So I think there's a lot that we can do to make sure that we're providing good and effective clinical care, using the right information at the right time, and also designing those programs with experience in mind.
No, and I think that you summarize it nicely. Although let me toot Humana's horn in this way, and that is, Stephen mentioned the new math. The old math for Humana as an insurance company is, you're a financial instrument focused on protecting and preserving, doing risk management. That's what you guys have done for decades, meaning insurance companies in general have done for decades. And to suddenly say that we're going to go from risk management organization to someone who's actually going to do health care, that's a pretty big shift. And that is an innovation in and of itself. And only when switching the mindset, like Stephen said about if you go from old math to new math, if you don't know what your new math is, you're not going to be able to solve really big world-changing problems. And that's why I think, that Humana, by shifting the mindset and saying, we're not protecting risk for some, this population. We're going to help improve the health of this population. Seems to me to be a big and nice thing to focus on. Do you see it that way? That that the insurance company, as a giant aircraft carrier, is trying to chase a little dinghy, as it were, in front of it, which is this health side? Or do you say that they are really equal in the sense of, health at Humana does mean as much as safety and risk protection as it does in the insurance side?
So here's what I'll say. We're going through an organizational transformation, and that is not something that takes a short amount of time. Right. You need incredible leadership, and you need support from leadership top down, and you support your employees at multiple levels to be able to deploy the changes that are required for something that is such a long-term investment. And I think what you're pointing out is that there are short-term ROI demands, and in the context of some long-term shifts that we think are important to make as we think about what's right for partnering with patients, and frankly, where we can add real value. And so that sort of short-term, long-term, I think it's probably something that many of our organizations struggle with. And how do you make sure that you're protecting the areas where you're making innovation, allowing those areas to discover what works, what doesn't work, have some failures, realize it's okay that you're learning, and then you sort of continue to move on. You need to build some protection around that. You also need to obviously have a risk calculation and a risk tolerance for that. And it's a continuing conversation, right? If this is not an easy journey, but again, if it was easy, we would all be doing it.
That's right. Great point. So Dan, so at LifeBridge, you guys are doing some very interesting things. Very specifically, a few years ago, you guys started talking about the unbundling of healthcare, especially starting on the primary care side. And I know that Mona mentioned, on her primary care side and in the ER journey. Talk to us about what does unbundling of healthcare mean to you? And you have a fascinating partnership locally with another health insurer in your area. So I'd love for you to talk about that and how that compares with maybe what you see that health insurers could do more of in order to help the health system side out. So first on the unbundling side, and then we'll move to the health insurance partnership that you have.
Yeah, unbundling can be used in a lot of different contexts in different industries. When we talk about it at LifeBridge, we're basically referring to the idea that we want to deliver a care pathway, a standard set of evidence-based interventions for a particular condition set in a particular population. And we want to do it with as light a touch as possible from a cost and footprint perspective, but with maximal benefit. And if you think about it, it kind of gets back to this, what I call the unified theory of healthcare buzzwords. You know, I mean, if Einstein were in healthcare today, you know, he might notice that precision medicine, value-based care, and digital consumer experience, you know, they all kind of reduce to right care, right place, right time, right patient. I mean, all of them, right, for different purposes. And as Mona pointed out, you need the right data and the right workflows to get to that sort of state of perfection, which is always, frankly, you know, something that is better or easier to imagine than to execute on. Mm-hmm. In unbundling, we've done things like look at a primary care practice and say, particularly in the last year, what percent of the services that they need to receive, whether it's counseling or reassurance or analysis, mental health access, et cetera, what percent of those things really need bricks and mortar? What percent of them need a provider at the appointment? What percent can be self-directed through mobile engagement applications? And because of the capitated system in Maryland and the support of our leadership, we've been able to have a lot of these unbundling of episodes and experimentation over the past few years, not entirely free of sort of business case concerns, but we don't not do something if it's not currently being reimbursed. And one of the reasons for that is hospital capitation in Maryland allows you to build a pretty reasonable business case around avoiding certain types of things, particularly if it's a type of hospitalization that is of the undesirable utilization type. So a repeat admission for someone who was dialyzed and then now is coming and getting dialysis. In our geography, frankly, those do not make you money. They lose you quite a bit of money because there's both capitation on the volume growth, but there's also penalty on certain types of things. And so we targeted certain things like CHF, diabetes, dialysis in those populations, built out care pathways, created mobile patient applications, home monitoring applications. And we view it as the unbundling of care because we're trying to take it out of the bricks and mortar establishment and bring it into the patient's home in some instances, into a primary care office in others. I think we're talking with a different word about the same exact thing that Mona's talking about. And it's interesting, we're talking as very much a provider organization, getting a broader footprint, doing some forays into value-based care, but LifeBridge is the largest health system in Maryland that frankly doesn't own its own health insurance company. But at least in this geography, we are able to do and very motivated to do a lot of the same things that Mona has been talking about. And a lot of that work has been around population outcomes, reversing or at least addressing health disparities. There was never any argument in the state of Maryland about these things. You referenced that there might have been some disagreement pre-COVID, but for us, I mean, COVID is the latest chapter in a book, and the title of the book would be something like there's a 20-year age or life expectancy differences between adjacent zip codes. And we are in one of our major hospitals right on the interface of those zip codes. So we never would have argued about this. This is something that is staring us in the face every day that we're trying to address. Part of the work to address that is the partnership you referenced with Care First. And the playbook for that goes something like this. If you're in this healthcare ecosystem of the United States, you might have noticed that a lot of healthcare innovation consists of providers adopting a new drug or device or technique, right? And being approved by the FDA and people starting to use it. And then payers innovating on the other side, ways to stop them from doing it, prevent them from getting, prevent them from doing it or have them do it in a different context, right? And so rather than be engaged in this arms race of one innovation, then prompting another innovation that sort of cancels half that innovation, our idea is work with the payer from the start, envision the seamless, experience-friendly, patient-friendly health system that gets to the outcomes that we all want with the payer at your side and innovate together. It's a hypothesis. I'm not, we've just started and embarked on this work, and it's not, we hope that Care First won't just be doing this work with us, right? And we hope, I think we're pretty honest with Care First that we're not just going to be doing this work with them, but we think that if you innovate as an ecosystem and think about what you're trying to provide employers and patients and governments and municipalities together, that perhaps there'll be less of this back and forth and more productive activity. And what we're trying to hammer down on is let's get rid of this 30% of healthcare costs that's administrative, right? I mean, that doesn't excite anybody. And if we have a $3 trillion plus health system, that means there's $1 trillion that we can work on and try to eliminate as much of that as we possibly can, because we want to see care delivered and that's what healthcare is about.
Yeah, that's such a great way of putting it. So we're going to open the questions up in a minute. But Stephen, what I'd love for you to talk about, and especially of everybody on this call, you're running an 18 hospital health system. You've got a lot more control than most of us do on this call to influence and maybe make change where you're sitting from. So what are the gauntlets that you think you're going to be able to throw down as CEO of such a big system, based on what you've learned in the last year that may be unobvious, to say, you know what, we have now seen that this is possible. So you can say to your board, you can say to your community leaders, you can talk to the state officials in your area to say, hey guys, we now know this is possible. Let's throw down a couple of gauntlets and go make this happen because we can do so. Is there something like that that you're willing to, push really hard on?
Yeah, I think the first thing we're pushing hard on is that, and it's been almost impossible to say this till recently, but healthcare is a consumer sport, and I blame everybody, including consumers. I mean, we've all been waiting for patients to have their "I'm mad as hell and I'm not going to take it anymore" moment. I wrote an article that I got in trouble for it, but that people have way too much respect for the medical system. And one of the points I made is, if you have an appointment at 8 o'clock, and I'm an obstetrician, so if you have an appointment at 8 o'clock and I show up at 8:45, 95% of the time, people say, "That's okay, Dr. Klasko, you must have had an emergency." And when I said it, that's true about 12% of the time. The other 88% of the time, I was at Grand Rounds, or I was at, and because the habits that get formed are different than any other consumer area. So the one thing is that we've been trying to educate consumers. Damn it, don't accept that. Right. God forbid, if you have pancreatic cancer and your doctor isn't nice and it takes a while to get in and you're going to the best doctor, that's one thing. But if you're having an arthroscopy, there's 123 doctors, and really good doctors in Philadelphia could do that. And, look at quality, access, cost, et cetera. So I think that's the first thing. The other thing is that we've started to throw some things out there that really create an alternative. So when you think about retail, I tell my board, I want to be Target and Walmart. Because if you think about Amazon coming in, there were retail folks that, oh my God, nobody's ever going to a store again. I got to be all E. Think Circuit City, where they're gone. There were others, think Sears and Pennies, that said, what a stupid fad. The day after Thanksgiving, everybody's always going to be happy to, line up and kill each other to get Cabbage Patch dolls. I'm dating myself, but that's Sears and Pennies. Target and Walmart said, we're really good at what we do, but we really need to get in this game also. And in one case, they acquired me, and in another case, they developed me. We're a 196-year-old academic medical center. And we're really good. And in some cases, we're best in a very large area in some of the things that we do. And that doesn't mean we shouldn't provide great service, but we need to always be there for that. After that, though, I need to stop thinking of people as patients. 97% of people in Philadelphia are not patients. They're people that want to be able to thrive without their chronic disease getting in the way. We were one of the foundational partners with Livongo. And Livongo is an interesting story when we talk about innovation, because the book behind me was written with Hemant Taneja. It was called Untitled Chapter, a manifesto for health assurance that we wrote together. And it really came with a chance meeting with Hemant. And the book starts out, what if a Silicon Valley entrepreneur and a CEO of a 195-year-old academic medical center walk into a bar, get married, and had a kid? What would that kid look like? How can we bring together move fast and break things with the mission of an academic medical center? And I think what's significant about that is when he invested in Airbnb and Stripe and Warby Parker, think about that. Airbnb, actually, you don't have to build more hotels to have a better hotel chain or a more valued hotel chain than Marriott. Stripe or Warby Parker, you don't have to build bigger stores than LensCrafters, just make it more convenient. When he got into healthcare, he said, what everybody says, can't get into healthcare. Well, he was the initial investor in Livongo. And the genius of Livongo is it does exactly what I just said. It said, diabetic person, you are not a patient. Steve is going to view you as a patient and tell you, come to my primary care office, come to my ER, come to my hospital. We view you as a person. who wants to be able to wake up in the morning and say, I want to have a good day and not have to think about my diabetes. So I think that the more we can play in that game, and that's what I tell my board. Now, it gets to that all-important payment model thing, and that's why partnering with companies like Humana or what you've done at LifeBridge is so important, because, it's the classic, it's hard to get somebody to do something when their salary depends upon them not doing it. And we saw some of that in the fragmentation during the pandemic, where hospital systems lost all this money because, they weren't able to make money from, ridiculously expensive elective surgery, and insurers in this case, did better because in most cases because of the medical loss ratio. Well, that shouldn't happen. So I think that we have to stop arguing about how we give more people access to this broken, fragmented, expensive, and inequitable healthcare system, and then hope will transform. We have to start to create some opportunities where consumers can force that change, give them alternatives, have the places that can't get it done fail, because that's important. And I'll leave you with just one example that's been really instructive to me. So, I'm an obstetrician, and we started a company that does Match.com between obstetricians and patients. And, I met my wife on Match.com. It's a cool service, and, you learn a little about each other. So it used to be, when I was in private practice, that a 28-year-old would be late for her period. She'd go to her 64-year-old male primary care doc, and he'd do a test and say, congratulations, Mrs. Jones, you're pregnant. I'm going to send you to my obstetrician, Dr. Klasko. And they'd say, thank you. Well, the chances today that a 28-year-old would do that are zero. They'll say, well, that might be who you'd go to. So I think the ability to start to match people together in the same kind of technology that we have for other consumer sports, and then have them access it and depend on that. So if somebody's not doing it, is where things change. And to me, that's what needs to happen. And it also needs to happen. This technology does not just make the wealthy healthier. So, we're looking at partnering with a company that's drone delivering food and drugs. They started in Africa, and they're now drone delivering food and drugs. They have a project in North Carolina, and we're going to be the next city. That's going to democratize cancer drugs. So you don't have to come in. I can't get a babysitter, so I can't get my infusion. Those are the kind of things that I go to my board and say, let's work together on these so that the incentives will match having healthcare join the consumer revolution.
No, I love it. And in fact, when you think about that kind of guidance from Stephen, Erica, what do you wish in your area leaders were doing to help make this story, now that everything is more exposed and that everybody understands how big the problem is? What do leaders need to do in your area to actually move the needle? And you've heard Stephen complain several times is, let's stop doing the same thing because nothing's actually changing. Do you concur with that nothing is actually changing? Or based on the last year, some things are starting to change, but now leaders need to actually rise up. Leaders like Stephen, who are at their positions that can actually have influence over hospitals and health systems, et cetera. What do they need to do in your area to make that happen?
I would say that's a great question. So a lot of the inevitable issues have been around for a long time, well before COVID. So COVID is just a dynamic that just woke everyone up. So we just had a tsunami alarm that just rang the bell one day. But bottom line is, there's been pervasive issues that have certainly been under the microscope, has been a challenge for way too long, and there's cause factors that play into that. So we've demonstrated throughout this past year that we can make change happen and we can impact progress. But why does the alarm need to be sounded for us to progress the industry forward? So I would say, as a collective now, so now that we've been forced together in the same space, really dissecting and looking up under the hood at these core challenges, including the social determinants of health, including the health equity challenges, including the gross level of inefficiency that we grapple with on a day in, day out basis, including the need to force ourselves to innovate and really think outside the box and take healthcare where it's been shifting for well over a decade and really speed it up and embrace these innovations full throttle. Embrace the hospital at home concept and embrace the virtual care delivery platforms and things of that nature. But I think that we need to stand strong collectively and really fight for a uniform agenda. Moreover, we need to make this a sustainable solution. We can't just throw immediate dollars at it and expect that solution to stick. We always have to reinvent ourselves through the overall process. So I would challenge us to drive and accelerate healthcare reform, couple with the changes that leaders just need to swallow the pill on and really push forward in order to make this a much more sustainable dynamic for everyone.
Yeah, that's great. And swallowing the pill, speaking of that, I think that's a great way to end this conversation in about 7 or 8 minutes. Remember, everybody on the audience side, if you'd like to jump on, ask some questions, please let us know, and we'll get you on video. Or if you just want to ask the question on the chat, that's fine. Otherwise, I'm reading some of those and talking about it here. So Dan and Mona, what I'd love for you guys to do is have a conversation like the following, which says, Mona from the Humana side says, I wish more healthcare providers would come to us with X, and therefore we can work together, especially now what we've learned in the last year, we can create a new system that we want. So what do you think the most progressive healthcare systems are doing, Mona, that you would like for them to either that they're not doing and you want to start them doing, or if they are doing it, you want them to increase? And that would make the partnering, like there's no way that our healthcare system is going to change unless providers and payers partner, right? And so that's a given. But what do you think, Mona, the healthcare systems should be doing when they come to their health insurance partners to be more successful? And then Dan, I'll give you the opposite question, which is what would you want the payers to do to make you guys more successful now that you've learned what you've learned over the last year or so? Mona, I'll let you take the first word.
So I don't know that it's something that I would ask. I think that as an ecosystem, we're trying to move towards more value-based care. So I think the conversation that I would love to continue to have with the community is, how do we help support that, right? How do we understand what the needs are? And understand what some of those providers in their local markets are facing, and how do we think about where we can help, rather than, I think what often happens, or the perception is that, we're here to help and yet maybe don't have a great sense of what the needs are, and create friction where it doesn't need to be. So I think for me, I think it's we're all on this journey together. We all, I think, acknowledge that we can do much better in terms of improving patient outcomes, whole community outcomes through investments in things related to social determinants of health. And how we get there is going to be, it has been a challenge in some places. It's going to continue to be a challenge. And how do we understand where we can help support that? So, I think we all need to continue to lean into that.
Yeah, and so could it be something maybe as simple as, hey, what are your value-based care ideas that maybe we haven't thought of? Or have you guys thought of stuff you've tried to find providers, but they don't want to do it because they like the fee-for-service world, right? So without naming names, we're not trying to call people out, but it's very real, of course, as we know, that that value-based care, some complaints are true, which is, what does it mean? And, what's my upside? What's my downside risk? That kind of stuff. But realistically, if we are on, it's almost like an addiction. Fee for service is like an addiction. We're not going to get off that addiction unless somebody just like rips off the drug and says, "I'm not giving you anymore." So
the real question, Shahid,
will change. It's not going to happen.
The real question is if you can do that without being part of the same system, right? I mean, we all talk about Kaiser and Geisinger and Intermountain, and they are integrated delivery and financial systems. And there's pieces where payers and providers, for a piece have done that. But we're in essence traditionally been very different animals. I have a few thousand beds.
Yeah.
And unless I was gonna if I owned a payer, if IBC and us were together, which is our largest payer, then we would probably look at how we best rationalize that, and the payer would invest in me doing that. It's very hard to do that, when so much of your revenue is still what is the nidus that gets you to go from here to there, and how much you're willing to lose. I'll just give you one example. When we started telehealth, we started with an all emergency medicine piece, 24/7, Jeff Connect, and we theorized we could move 50% of our non-trauma, non-ambulance patients out of our expensive, inefficient ED. At the time, we would have lost $30 million. Because at that time, insurers were willing to pay us an average of $1,500 if I had a sprained ankle and went into our ER and they did 2 CAT scans or whatever, and an average of about $89 between telehealth, urgent care, and an appointment the next day. So what we did is we partnered with an insurer that's our TPA for our 32,000 employees, where we're the payer, the provider, and the employer, and it was a wild success. And now we've expanded it to other payers. So it can happen. But it's just not going to, it doesn't happen organically unless you have a real alliance.
Yeah, no, that's a great point.
And I think, to that point, I guess I would also say, what's a glide path? Because you don't go from 0 to 100. And so not just what are the incentives, but also what are the incremental gains that you can make over time that help you sort of set up that culture that, again, you're not going to reach overnight.
Yeah. And so, Dan, I'll let you have the last word here, because the glide path that Mona talked about could be seen in Maryland. You've got a capitated system. And in capitation, you do get penalized when wrong care is sent to the wrong group by both zip code as well as other regional requirements. So is that model in Maryland a proper glide path that Mona is asking for? Or do you think that there's more that payers and providers could do based on what you're learning with Care First that doesn't really need government intervention to go change something, but just the alignment that Stephen was mentioning about could happen, not naturally, not organically. Somebody's got to force the issue. Yeah. And is that what you're seeing in Maryland?
Well, capitation, I mean, just to be clear, within the state of Maryland at the hospital level is very much driven by government forces. So it's not something that happens, or the market doesn't organize that on its own. It's a really good question. I don't want to say that Maryland is nirvana. For someone that wants to do the type of work that the four of us do, there are parts of hospital-based capitation that work very nicely. It's one of the reasons that I went from a national job with Evolent and came back to Maryland, because we don't have a lot of the internal competition between hospital presidents within its system, for example. It is very different. But I also, want to be very clear that there are unanticipated consequences of that as well. So if you look nationally since 2014 and compare HCAHPS scores and hospital waiting times nationally to Maryland, we're not moving in the right direction as a state in that period of time. And so there's good and bad. When every hospital is trying to fill itself up, they will actually maybe even be a little bit more patient friendly. They will advertise shorter wait times, like when you get out of an airplane in Orlando, Florida, every hospital system wants to tell you what their wait time is, right? Not really going on as much in the state of Maryland, right? We're all trying to work on it, but what the state and the government have learned is that as you create the system, you then have these unanticipated consequences, and then you have to regulate on those. And you don't want to have regulation gone awry, because that's not going to be efficient either. You just in terms of the glide path and the first question you asked, like, what do I wish I would see from a payer or payers in generally? I think more standards around automating administrative transactions. It's tough because payers all want to have a differentiated offering to employers. So they don't all want to do the same thing, but we kind of need them to do the same thing. And that's one of the reasons that Kaiser is a closed system, and some of the other systems Stephen referenced one of the reasons they're able to do well and create a more uniform experience is that they're not driving themselves crazy with 50 different types of payer hoops to jump through. And it'd be great if payers could sort of get on the same page about some of the experiential aspects that Mona mentioned. What are the common things that we all want for our loved ones, right? Not so much value-based care, but values-based care. You know, what do we want? What does everyone want it to look like? Can we get on some of the same page about that, have standardized processes across payers? And I think the big thing is, can we see data from payers the way payers keep on telling us we'll be able to see it? You know, we just never get there. And it is as laughable as suboptimal EHR instances. It's just one of these things that in healthcare, we can't seem to get there. And it's frustrating. And it would be great to see a different reality with that.
And do you feel like the patient access rules or the payer-to-payer exchange rules coming up next year, like this year, and then payer-to-payer coming next year, is that going to help providers in any way because their patients now have access to payer data? Would they be able to forward that on to you guys on the provider side?
It may, you know, for certain types of consumers. I do worry a little bit about like the digital divide and just the information divide. I think about my parents, who are pretty sophisticated Medicare age people. You know, could they figure out and ferry all that information as their lives gotten more complicated on their own? It seems like there's a real possibility there'll be more disparities based on patients that know to default into that and know what to do, and those that are left to figure it out on their own, that are maybe more disenfranchised.
That's hard to hear because Stephen wants to get even more and more consumers involved. Mona said that we got to get the consumers involved. These are one of the areas, especially the patient access rule coming up in June or July this year, which got pushed by 6 months because of COVID. I think that we may be underestimating the consumers, and that if we open the data up, and you know, Mona, especially from your perch as a data officer at CMS just a couple of years ago, the idea was the more open data you provide, the more the app industry creates more innovation. And maybe the gaps that we're thinking about, Dan, here could
the blue button initiative. You're talking about the blue button and that type of work. Yeah. I mean, deregulation, I think in general, it can lift all boats, but as a rule, it doesn't tend to solve for equity issues.
Yeah.
If you look at the history of deregulation.
And to that point, Dan, I mean, I think what we tend to do, and all of us, including government regulations, it's like treating the rash of secondary syphilis without getting to the systemic problem.
Mm-hmm.
You know, we talked about broadband. I mean, in Philadelphia, that was the #1 reason you would die or be hospitalized if you didn't have broadband, because you couldn't access telehealth, you couldn't access online education. That's a big deal. And so instead of doing these little things, we should have a national broadband thing. We've talked to Comcast and others about that. Even the transparency rules, yeah, that's good, but it's not real transparency. It's putting my charge master, on the internet. And if you look at Philadelphia, everybody's found cute little ways not to make it more transparent, but to make it almost impossible, unless you are a software engineer. Click these 27 things. I've solved what CMS has told me to do, so, nobody's really being forced by the consumer to really be transparent. I need a hip replacement. What's it going to cost me? What's your outcomes? What do people say about you? And then I want to go to your competitor and do the same thing. That's transparency.
Yeah.
Well, if I can just add one thing, regulations are an enabler. They're not a solution. And I think what has happened in healthcare has just been, I wouldn't even say innovation, but tweaks on the margins rather than a transformation in business models with the end consumer in mind. And so I think we need to look at the regulatory changes, the changes in the technology infrastructure as enablers, but not as the sort of end conclusion. It then involves all of us leading in to think about how do we lead these transformative efforts, and realizing that it's going to be painful in the short term, but in the long term, it's going to be an incredible competitive advantage if you can do it well and if you can really put the consumer at the center of that process.
Yeah, but that gets down to leadership, right? The four of us are on
Absolutely.
because we all work with companies that have been willing to take that leap. But, you know, in my world of $5 to $10 billion academic medical centers, the average CEO is a guy that moved up through an academic ladder, you know, has been doing his job for 20 years, is going to retire in 2 years, and he could either work harder than he's ever worked and upset all the doctors that he, you know, got to this point, hoping that things won't change, and that's what's happened. It's like, I'm getting my LTR in 2 years. I'm going to count on the fact that CMS isn't going to force me to do things, or Humana isn't going to, you know, change my world enough. So that's what I'm going to do. I mean, I know it's a cynical approach, but that's partly why it hasn't happened. And by the way, the same thing is true in a lot of the Blues plans where, you know, they don't have the technology and they're not doing what you're doing.
Well, and I would say we don't need everybody to change, right? That's okay, actually, because the winners at the end of the day will lead the way, and there'll be forced transformation for those entities that aren't actually leaning in. So I'm okay with that.
No, that's actually a pretty optimistic view, and this is great. We're a couple minutes over, but this was great. Summary here. Everybody was so enthralled with what you guys were saying, they didn't want to interrupt with questions. So good to hear that. But you guys did awesome. Stephen, thank you so much for joining us. Erica, Mona, Dan, and we'd love to have you at a future Health Impact. And the rest of the audience, please do come by. We had a great day, as you saw today, and we'll have an even better one tomorrow.
Thank you all so much. Thank you for taking that live. You did an amazing job. Now we have 2 great sessions. That was fantastic. So thank you.
All right, great. It was a great day, everybody. Thanks for joining.